Medurstand Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today I'm going to present this special lecture because of the relevance with Ramadan. Millions of people, they have diabetes, and many of them, they would like to fast. And this lecture would help you understand how these medicines are better used and how we can optimize them during the month of Ramadan so that these individuals, these patients with diabetes, they can fast safely. So the topic is optimization of anti-diabetic medication during Ramadan. And I have to make a few disclaimers. First of one is that most of these guidelines are based on evidence and are expert opinions. So you can follow them with confidence. And of course, there will be situations where you will have to make some amendments in these guidelines, but mostly they will be relevant and applicable in most patients. And I have used some trade names only for better orientation, better understanding, and not for any monetary gains because some of the newer drugs they are well known with their trade name. Since the audience, the target audience of this lecture is not only medical students or postgraduate students, the target audience also includes practicing family physicians. So I thought that I would use trade names in some cases because they prescribe drugs with their trade names so they can better understand and apply these concepts. Fasting is patient choice. We, of course, cannot tell anybody to fast or otherwise. But if somebody wishes to fast and he is or she is diabetic, then we have to make certain changes in the medication so that the fasting remains safe for his health. So with these few disclaimers, we are going to start with the presentation. And what are the physiological changes which occur due to prolonged fasting? And because of these physiological changes, body has to face few challenges. And one of them is prolonged food deprivation. Now, in normal days, we hardly stop eating. I mean, there are hardly periods of food deprivation for more than few hours. But during Ramadan, you cannot eat or drink for 16, 17, 18 hours. So this is a major physiological challenge for the body. Then change in meal timings. Our typical meal timings are different, but in Ramadan we have to take a very early meal, which is called sahri, and then we have to take early dinner, which is called iftari. So these timings are different. That is another challenge for the body. Then change in the meal composition is also a challenge because the meal for Sahri is different than our usual breakfast, and meal at Iftari is also very different than our usual dinner. There's a lot of carbs and there's a lot of fats in that, and there's a lot of fried food, so that is another challenge. And then the change in circadian rhythm. Our body metabolism is linked with our sleep pattern also. Now, in many cultures during Ramadan, sleep pattern changes completely. But even in, even if there is no complete change, there is significant change in our sleep pattern. So that change in circadian rhythm also have some metabolic implications. So if our body fails to meet these challenges well, then there are certain risks. What are those risks? The major risk is that of hypoglycemia. If somebody is not going to eat for 16 hours, and especially if that patient is on glucose lowering therapy, there is definite risk of hypoglycemia during the day, especially in the afternoon, because that is a time when sugar will be dropping and patient will not take his lunch, and there is a serious risk of hypoglycemia. As you all know, when we treat diabetes, we are mostly concerned about hyperglycemia, but hyperglycemia can cause damage in years and decades, whereas hypoglycemia can cause sometime irreversible damage within minutes. So we just can't take the chance of hypoglycemia. So I think one major objective of making changes in the medication in diabetes prior to Ramadan is to prevent hypoglycemia. Then dehydration, of course, when we're not drinking water, and especially when there's a summer weather, so there is the risk of developing dehydration also. Then hyperglycemia also. Typically, we take aftari, which is very rich in carbs, and patient feel justified to drink sugary drinks also, and also take many things which are rich in carbohydrates. And if patient takes medication after the meal, there is risk of hyperglycemia after aftari also. So we have to prevent that also, because severe hyperglycemia can be damaging also. Then, in some rare cases, there is a risk of ketoacidosis. Now, luckily, this risk is very low, although it is potentially serious condition. So, we will be concerned about this risk of ketoacidosis. So, out of these four risks, I think the major risk is that of hypoglycemia. So, we will talk about hypoglycemia in little more detail. So primary objective is to prevent hypoglycemia and also severe hyperglycemia. And I think if we say that we would like to prevent both hypoglycemia and even modest hyperglycemia, most probably we will not be able to succeed. So I think if our objective is more realistic, we must prevent hypoglycemia. But if we are able to prevent severe hyperglycemia, I think the purpose will be solved. So modest hyperglycemia for a short period, for only 30 days, perhaps would not be much damaging, because whenever we try to prevent hyperglycemia, there is risk of hypoglycemia. So that is our objective, and that is the basic of that is the reason why we have made these recommendations. The risk of hypoglycemia is not the same in every individual with diabetes. Now, there are two main factors. One is patient himself, the profile of the patient. I will just uh, show you various uh, factors related to the patient which make predispose him to hypoglycemia. Then there is a there are factors which are related to the medication patient is taking. There are certain drugs which are much less likely to cause hypoglycemia as compared to others which are more likely to cause hypoglycemia. In normal life, we use them because when patient is allowed to eat or drink in case of hypoglycemia, then hypoglycemia cannot be, then it is not that major risk. So during Ramadan, because patients would most probably try to avoid breaking his fast, so we would like to avoid these medication which are more likely to cause hypoglycemia. Now, the factors related to patient: previous history of hypoglycemia. If somebody has never experienced hypoglycemia in the past, it is less likely that he or she would have hypoglycemia during Ramadan also. But another person who has been having hypoglycemia frequently, otherwise also, is at greater risk. A patient who has a tighter control. Now, this is simple logic or simple common sense. Somebody's sugar remains very high, so the chances of hypoglycemia is much less as compared to another person whose sugar is very well controlled. So the same person whose sugar is very well controlled, uh, and when he starts fasting, there is a risk of hypoglycemia. Then renal disease, kidneys have very important role in glucose homeostasis. After liver, kidney is the main organ which causes gluconeogenesis in case of hypoglycemia. and that mechanism may be impaired. If somebody has renal disease, which many patients with diabetes may have, minus CKD1 or 2, where actually kidney functions are well preserved. Other patients who have CKD 3, 4, and 5, they would be at particular risk of hypoglycemia. Liver disease, again, liver disease is common in our society because of hepatitis C and B. Now, liver disease, when I say liver disease, I actually mean cirrhosis. Uh, Fatty liver is also liver disease. A fatty liver would not cause much of an issue, but if somebody has chronic liver disease and that also decompensated cirrhosis, that would definitely be a major factor in the pathogenesis of hypoglycemia, because liver is the main organ which fights hypoglycemia by producing glucose, the mechanism of gluconeogenesis and glycogen lysis. Then frailty, somebody who is very, very frail, elderly, without much of body reserve, without much of glycogen reserve and fat reserve, that person is also at a greater risk of hypoglycemia. Now, when we talk about medication, there are two groups of medication which are particularly responsible for hypoglycemias. One is insulin. Insulin, of course, the main function of insulin is to lower glucose. If somebody is taking insulin, particularly the one with which are which have a peak mechanism, the profile is not very flat. They have a peak action like human insulins and NPH insulins. They are likely to cause hypoglycemia. In fact, basal insulin and rapid acting insulin analogs can also cause hypoglycemia, but chances are relatively less. Then secretagogues. Now, secretagogues are the drugs which stimulate beta cell to produce insulin. And the main example is sulfonylureas. We have some other drugs also which cause, which stimulate beta cell, but their mechanism of action is glucose dependent. I'm shortly going to talk about them in more detail. But here, I usually secretagogue refers to sulfonylureas, because sulfonylureas, they stimulate beta cell to produce insulin even if somebody's existing glucose level is normal. So insulin will lower sugar further. Many other medicine, they do not cause hypoglycemia uh, commonly. Now, we can classify anti-diabetic drugs into three classes. Now, this classification is based on the potential of causing hypoglycemia. We can classify into those which have low risk of hypoglycemia and those which have high risk of causing hypoglycemia, then those which have moderate risk of causing hypoglycemia. Let's first talk about the low risk hypoglycemia classes. Now, I'm sure you're all familiar with these drugs: metformin, SGLT2 inhibitors, acarbose, thiazolidinediones, TZDs, DPP4 inhibitors, and GLP-1 receptor agonists. All these drugs, they have low potential of causing hypoglycemia. Now, if I ask you, what is common between these four drugs? This is a very, very diverse group. They are pharmacologically different. Their mechanism of action is different, but I have grouped them in one based on their one unique feature. And that unique feature is that these drugs, they lower glucose, but they do not stimulate beta cells. Since they do not stimulate beta cell, they do not produce insulin. They work through different mechanisms. For example, metformin works by improving insulin resistance in the tissues and by also suppressing gluconeogenesis in the liver. SGLT2 inhibitors, they work through kidneys. They promote excretion of glucose, not affecting beta cell. Acarbose works through the gut. It slows down the absorption of glucose. And thiazolidinediones, they work on liver, they improve glucose resistance, they also work on the fat cells. So all these drugs, they have effect outside beta cells. I think one simple rule is that if there is any anti-diabetic drug which does not stimulate beta cells, is less likely to cause hypoglycemia. So this is one group. Then the second, what do you think is common between these two groups? GLP-1 receptor agonists, they are the drugs which actually stimulate beta cells but in a glucose dependent pattern. That means beta cell stimulation will halt once glucose level become normal. So it is a secretagogue, but since the action is glucose dependent, the potential of causing hypoglycemia is much less than sulfonylureas. DPP-4 inhibitors are the drugs which prevent degradation of our endogenous GLP. So they also have effect which is glucose dependent. So all these drugs, they have low risk of causing hypoglycemia. Now let's talk about this group uh, with the group which has got high risk of or high potential of causing hypoglycemia. Old generation sulfonylureas. The only example of this class which is in practice, which is used, is glibenclamide. Now, this drug is very commonly used, and this drug is incredibly cheap and incredibly effective, so it is very, very popular. And many people are using, but this is actually very long-acting drugs, and many times it is prescribed twice a day. The action is more than 24 hours. Now, if it is taken twice a day, then there will be cumulative action in the body, particularly if there is a kidney disease in the background. So glibenclamide is very notorious to cause prolonged and problematic hypoglycemias even in non-fasting state. So I think this is a drug which has got, I would classify it as high potential of hypoglycemia. Then intermediate acting insulins, which are called NPH, because the profile of these insulin is with a peak. So the time which correspond with the peak, that is a time when there is a risk of hypoglycemia. Pre, excuse me. So the pre-mixed human insulin, because they also mostly contain NPH, and because of the NPH component, there is a risk of hypoglycemia 6, 7, 8 hours after injection. And because of the human insulin, there is a risk of hypoglycemia 2 or 3 hours after injection. So I think this is the group of drugs which have a relatively high risk, high potential of causing hypoglycemia. Now let's talk about those drugs which have moderate risk of hypoglycemia. This have already highlighted. Now let's move on to the moderate risk of. So newer generation sulfonylureas, for example, glimepiride or gliclazide (MR). These drugs, they are sulfonylureas, but their action is somehow less pronounced, less marked as compared to glibenclamide, and there is evidence that these drugs actually they have lesser potential of causing hypoglycemia. Then basal insulin. There are insulins which have very, very flat profile, and I'll show you they have less risk of causing hypoglycemia. And then we now have combinations of basal insulin with GLP receptor agonist combination. They would also be classified as having moderate risk. Now, based on this concept, we have two groups now. Those patients who have maximum risk of having hypoglycemia, a vulnerable patient. I just described some factors related to the patient. If those factors are present, plus that person is on medication which has high potential of causing hypoglycemia, this patient would be called high risk patient. And on the other hand, we have a patient who have minimum risk of hypoglycemia, less vulnerable patient, a patient who has normal liver, normal kidney, and is otherwise healthy, relatively young person. that is less prone to develop hypoglycemia, and plus that person is on medication which also has low potential of causing hypoglycemia, so there would be minimum risk. But of course there would be different grades and shades. For example, a vulnerable patient taking low potential medication or less vulnerable patient taking high potential medicine, they would have intermediate risk. So I think in every individual we need to define the risk, and accordingly we make a plan for him.